So hello, my name is Pam Ellsworth. I'm the Division Chief of Urology, and we're going to talk today about catheters, tubes, and drains as they pertain to pediatric urologic patients. Okay, so first of all, I have no disclosures pertinent to this presentation. So what are the goals or objectives of this discussion? And so the first one, I think, is to be familiar with the different types of catheters, tubes, and drains that we use in urology. To understand some of the different procedures where we use these tubes. To be able to troubleshoot a malfunctioning catheter or tube. And lastly, to recognize when to call for help. So this is a Foley catheter for those of you that have not seen one or had one. And if you look at this, you will see that there is a long tube that has two ports at the end. The one that has got a little orange pink on it, which says 10 mL, is the balloon port. And this is really important to actually look at in terms of the amount of fluid that you put into this port. Because this one happens to say 10 mL. There are catheters that are as small as a 1.5 millimeter balloon port. It is asked that you inflate this with sterile water, not saline. Saline can actually cause precipitation within the balloon and make it difficult to deflate the catheter. You look at the right-hand side of this, the top part, that's the balloon when inflated, and the bottom is collapsed. So you're instilling fluid into this balloon, and that will keep the catheter in place. The other port is the port that you would connect to the Foley drainage bag or leg bag, depending upon what is requested. When these catheters are placed, we ensure that we see urine coming out prior to inflating the balloon. So what are the indications of use of a Foley catheter? I think many people are aware of the CAUTI restrictions and concerns about catheter-related urinary tract infections, so we are cautious in the use of catheters. We typically will use a Foley catheter during wound healing for urine drainage when we are operating on the urinary tract, the bladder, and urethra potentially. We look at to decrease the potential for post-surgical upper urinary tract leakage when we do complex reconstructions of the kidney, where we want to ensure that there is no back pressure of a full bladder on the upper urinary tract. In children that are critically ill, where we are trying to determine accurately their intake and output, a Foley catheter is helpful for assessing urine output. And if there is any concern for postoperative urinary retention, a catheter may be used over the short term, and if the retention appears to be of longer duration, an alternative method such as clean intermittent catheterization may be utilized. So when we use the Foley catheter for wound healing, typically the surgical procedures that I would utilize this are in a child who has a history of urinary tract vesicoureteral reflux, whereas urine goes backwards from the bladder up the ureter to the kidney. With a history of infections, we will often repair this. There are a variety of ways to do this, but in an open ureteral reimplantation, when the bladder itself is opened, a catheter is placed to allow for bladder healing prior to spontaneous voiding to prevent leakage. In children that have ureteroceles, a cystic dilatation, swelling of the distal, the lowermost part of the ureter within the bladder, a bulge within the bladder of the ureter related to a blockage at the opening of the ureter. When we go in and excise these and then reimplant the ureter, again, because the bladder is opened, a catheter is left indwelling. Bladder diverticulum are much like diverticulums in any area of the body, such as colonic diverticuli. If there is a large diverticulum that we remove, again, a catheter is placed because we open the bladder. And lastly is bladder augmentation, where we take a child who has a small bladder capacity associated often with a high bladder pressure, which typically occurs in children with a condition called spina bifida or myelomeningocele, We enlarge that bladder to allow that child to hold urine for longer periods of time, as well as lower the pressure in that bladder to prevent damage to the kidneys. That patch is with a piece of intestine most commonly, and again, because of the healing of that and the risk of leakage, a catheter is left indwelling. For conditions in which we suspect that there's a risk of potential leakage in the kidney area higher up after surgery, a catheter may be left in place. And the two conditions that we would be concerned about are children who have a blockage to the outflow of urine from the kidney, a ureteropelvic junction obstruction, whereby we go in and remove that blocked segment and attach the ureter back to the kidney, or in the setting of a child that has a ureterocele, that cystic swelling of the ureter in the bladder that is due to a blockage to the outflow of urine from the ureter into the bladder. If the kidney tissue associated with that ureter does not function well, then sometimes the best way of repairing that is to actually remove the top part of the kidney. Again, a catheter will be left in post-op to minimize any potential for urinary leakage after that procedure. This is the schematic of a UPJ obstruction. This is a test where dye was injected. We don't typically do this stage because this is associated with radiation exposure. But on your left side facing the screen, you see a normal appearing kidney with a nice thin ureter. On the far right, you see what I call a shmoo. This is a dilated, massively dilated kidney with massively dilated calyces, and that big round balloon that doesn't show up as bright white is actually a massively distended pelvis, and there is delayed excretion of contrast into this collecting system. And that teeny wisp shows you all that's leaving that collecting system because of an obstruction just at the bottom of that dilated pelvis. We repair that by literally removing that segment. So you can see we are cutting across the pelvis of the kidney as well as the ureter and sewing it together. That anastomosis is not watertight upon completion typically. And so a catheter prevents back pressure, which would increase leakage. So for children that have complex, long-duration surgical procedures, children with sepsis, or those that have had an open belly for a period of time in the surgery, that they're concerned about third spacing in the abdomen with distension of the bowel from edema, in those individuals, we want to know accurately what is their volume status, and a Foley catheter is used often to be able to have detailed information on urine output. Children who may be at risk for urinary retention are those that have had perhaps an epidural anesthetic during their surgery, spinal surgery, and in urology, if we do a ureteral reimplantation from the outside of the bladder, an extravesical, and do it on both sides, the literature indicates that there is the risk of a transient urinary retention related to us affecting the nerves supplying the bladder. So all of these would be cases, again, where a Foley catheter may be placed. How do we manage Foley catheters? I think this is just a brief overview of some of the salient features regarding Foley catheter management. It's a closed system, and the goal is to keep it sterile as much as possible. A Foley catheter placed by the urology service should not be removed unless instructed by the urology service. Again, if we do a complex bladder augmentation, and particularly if we were to affect the outlet of the bladder and the catheter is removed, we may not be able to get it back in. Do not deflate the balloon unless instructed to do so. Again, good intentions, maybe the catheter is pulled down, I'll just deflate the balloon and push it back in. The risk is child moves, catheter falls on floor, and no longer do we have a catheter in place. So please make sure that the service is aware prior to affecting the balloon. Now, people will say, what do I do if a catheter is not draining? First and foremost, check for a kink. Pediatric catheters are small. They are flexible. And a little kink can cause that catheter, which is just child crossing leg, how it's taped, how the diaper's put on, can cause a kink in the tubing. So that's the first and foremost. If the urine is bloody and there's a concern for obstruction due to clots affecting the drainage, and again, the ports of these are quite tiny, gentle irrigation can be done first. If these troubleshooting maneuvers are not effective, then it would be best to contact urology before further manipulation. So, Foley catheters are typically placed at the bedside for bedside drainage, and a couple things that we want to be very careful about. We cringe when we see the dangling catheter. Okay, that can get stepped on if it's attached to a bag and they're moving. It can put tension on, particularly if it's a male urethra. That can actually potentially put a child at risk for strictures. Pediatric urethras are extremely sensitive. If they're dangling and not accurately secured, again, it can lead to kinking. And we want to make sure that there's dependent drainage because, again, the goal of this is to monitor urine output, decrease back pressure, and leaking. In small children, we may actually violate that rule of a closed system just because sometimes the drainage bag is bigger than the child. And in infants, we may place a catheter to double diaper drainage. That is far less risky than the bag that's bigger than the child that mom's dragging on the floor when she's holding the child and walking. So in such cases, we may elect to do a double diaper drainage. This is a different type of catheter, a suprapubic tube. This is not passed per urethra into the bladder. Rather, in some of these children who have had complex repairs, such as the bladder augmentations, where we want every chance of excellent drainage, particularly when we look at that the Foley catheter has a small lumen, and we get concerned if we put a piece of intestine into the urinary tract, when we use it as a patch and it can produce mucus, that it could plug that small lumen. The suprapubic tube gives us a larger lumen. These are often anchored in place at the time of the surgery to the bladder or to the abdominal wall. However, if you look at these little prongs that you see are quite flexible. So with pulling on this, they can get dislodged. So I indicated that we use that for bladder drainage. The only other indication is a child, and we're not doing trauma here yet, but in the future when we do, traumatic pelvic injuries can be associated with urethral disruption, where the urethra is torn and there is no continuity with the bladder. In that type of setting, we have to have bladder drainage, and typically a suprapubic tube will be placed at that time. These are placed intraoperatively by and large in children, different than adults. We don't remove these at all costs. If they become dislodged and we see them sitting on the belly wall with the suture right beside it, we would contact urology. Sometimes if these have been placed for a duration, the tract will actually be healed and we can actually slip a catheter right through that tract. If these are bloody, they can be irrigated. If, however, you are trying to get urine or fluid in and you are unable to aspirate that fluid back, that would be a concern that that tube may have pulled out the bladder, and we would recommend not continuing to flush that tube. Okay, so we're going to move away from catheters, suprapubic tubes, and Foley catheters and talk about drains. The most common drains that we use are Penrose drains in urology. They are primarily latex-free, and again, we use these in conditions or surgeries where we think there is a risk of urinary leakage or bleeding that we want to be able to monitor this. So if we think about the procedures I talked about, that's our pyeloplasties, where we are actually disconnecting and re-sewing the urinary tract together. Our partial nephrectomies, where we are literally shaving the top half of the kidney off, and we could get into the collecting system of the bottom part or have some bleeding, and our complex bladder reconstructions. Other tubes that we use are tubes called double J stents. These are internal tubes that are not visualized unless they become malpositioned. They're hollow and they have a curl at both ends that keep it in place. These tubes are placed They actually extend from inside the kidney down the ureter into the bladder. We use these when we do pyeloplasties to allow for good drainage of urine through the anastomosis when we anticipate there's going to be some swelling postoperatively, as well as keeping that area open to minimize urinary leakage. After we do ureteral procedures, the most common being ureteroscopy and laser lithotripsy, fragmenting a stone with the use of a laser fiber, we place a double J stent for two reasons. One is the surgical trauma related to that can cause swelling and a secondary short-term obstruction, or pieces of the stone fragments could obstruct the ureter. So a double J stent allows for drainage while swelling resolves and pieces of stone that are left behind can pass along the stent. And then for children in whom we have an episode of acute ureteral obstruction, whether it be related to a stone or a stricture or a congenital blockage of the ureter, and we want acute drainage and planning a subsequent intervention. This is an example of a double J stent. Facing the screen, the left side is it in place. You see a curl sitting up in the kidney and a curl in the bladder. This just shows you what the curls look like. By placing a guide wire through this stent, it straightens it out to allow us to put it in through a specialized scope, a cystoscope. The curls are a double-edged sword. They hold that stent in position so it doesn't migrate down or up. Typically, the risk is migration down with the flow of urine from the kidney down the ureter into the bladder. However, you can imagine when you empty your bladder, that little curl bangs into your bladder or pulls on your kidney and can cause some pain associated with it. We remove these often in the operating room cystoscopically on younger children. There is a string that's attached to it that in older children you can have that string exit the urethra and tape it to the legs. I don't know, but I've found when I talk to adolescents about that, the look I get is, no, thank you. But it can be done in the office for a more stoic adolescent. As I said, they can be the source of pain in the bladder or flank with voiding. They can irritate the bladder, causing frequency and urgency. And rarely they can migrate, and the call we get is typically the individual who has had a stent calls complaining they cannot control their urine. It's just coming out, I can't control it, and it means that the stent has migrated into the urethra, has passed the bladder outlet, and so they now have a nice way for their kidney to drain just right into the urethra and into their underwear. Last one is urethral stent. So we talked about a ureteral stent, the double J stent, and now a urethral stent. This is different than a double J stent. It's basically analogous to a catheter without a balloon and no balloon port. We use it after urethral surgery, most commonly after a hypospadias repair. There is no balloon to anchor it in place, and so typically this catheter is anchored in place with a suture that we place through the glands. So these stents can obstruct. The signs of obstruction are a dry diaper or a parent stating that I see the urine draining around the catheter. They can become kinked. And with newer diapers and the cutting that little hole to allow the catheter to pass through it into a second diaper, we found that diaper beads are a great source of obstruction. And so when that hole is made, if we actually tape around that hole, we can prevent diaper beads from leaking out of the diaper. Again, if there is no kinking, the catheter appears to be in place, aka we don't see it attached to the penis but the tip visible, then we can gently irrigate that to see if it meets with resistance. If there is resistance, obviously contact the urologist before removing. And I think that's it for catheters, tubes, and drains.